Welcome to the RCI GDAS webinar titled Screening Tools for Dementia and Mental Health. It is presented today by Dr. Anthony Weiner. Also today we are going to have Tom Snyder from the Georgia Department of Aging Services available for questions at the end along with Dr. Weiner. Before we get started, let's cover a few conference details. If you have a question during the conference, we ask that you type in your question. All questions will be answered at the end of the conference. Also, if you are at your own computer station, a post-test survey will pop up at the end of this webinar. There will be 10 questions about the webinar and a few personal information questions such as your name and email address that will enable me to send you your certificate. If you are not at your own computer, copy down that link that is posted on the last slide of the presentation. Then use that link at your own computer to complete the post-test. Certificates will be sent within 1 week after closing of the test. Please complete this test before May 13th to receive your certificate. We are now ready to begin. Welcome, Dr. Weiner.
Good morning and welcome, everyone. Thank you for your interest and the time you're devoting to today's webinar entitled 5 Behavioral Health Screening Tools. As Director of Outpatient Geriatric Psychiatry at Massachusetts General Hospital, I'm delighted to be offering you this webinar. In the hour or so ahead, I plan on presenting these screening tools to you over the next approximately 40 minutes. And then, as Elaine has said, we'll have time for questions and then the post-test after that. I've selected these 5 behavioral health screening tools because I see them as being very useful, addressing important problems in our line of work. I will describe the purpose of each of these, the ways to consider administering them, and I hope that you find this webinar useful. As an overview to start, the 5 screening tools on which I will focus primarily are those for mild cognitive impairment, delirium, alcohol abuse, and depression. I hope that you find these informative and this webinar helpful, and that it leads to driving meaningful change and improvement in the work that we do together in the field of behavioral health. I start with the first screening tool, the first slide you see after the title slide of the Montreal Cognitive Assessment.
Dr. Weiner, do you need to hit the next button to move to that slide?
All right. Do you see it now?
No, sir.
I have moved over to it. Do you see it?
No, sir. Let me do it. Let me try it.
All right.
Okay, there you go.
Very good. Thank you, Elaine.
You're welcome.
So the Montreal Cognitive Assessment was designed as a rapid screening tool for mild cognitive impairment. It assesses different cognitive domains. When we say cognitive, we refer to the act of processing or knowing something, and domain, a sphere of activity. So the different domains which the Montreal Cognitive Assessment tool assesses include attention and concentration, executive function, by which we mean the way a person organizes, abstracts, plans, or sequences information, memory, language, constructional skills, conceptual thinking, calculations, and orientation. One of the terrific things about the Montreal Cognitive Assessment is that really it only takes about 10 minutes to administer. So it is a terrific and very useful investment of time in assessing important cognitive functions of a patient or client. As an overview, there's a total of a possible score of 30 points on this assessment, and a score of 26 or above is considered normal, and I'll detail that a little more in a moment. But as you see on the screen in front of you, and an image of the Montreal Cognitive Assessment, which is known in colloquially as the MOCA. It starts with assessment of visuospatial and executive functioning by starting with the alternating trail making test, again for visuospatial and executive function assessment. The way to administer this is as follows. The examiner instructs the subject, please draw a line going from a number to a letter in ascending order. Begin here, and you point to the circled number 1, numeral 1, and then say, and draw a line from 1, then to A, then to 2, and so on. So alternating in ascending order, numeral, letter. And then you say, end here, and point to the letter E. The way to score this is you allocate 1 point if the subject successfully draws the following pattern. Alternating is then you understand 1A, 2B, 3C, etc., without drawing any lines that cross. Any error that's not immediately self-corrected earns a score of 0. Now moving across the page, left to right, the next test is for visual constructional skills, and it's drawing the three-dimensional cube illustrated there. And the examiner instructs the client, please do the following, pointing to the cube. Copy this drawing as accurately as you can in the space below. After the drawing's done, you score this as giving 1 point. Remember, we're working towards a perfect score of 30, ideally. So you give 1 point is allocated for correctly executed drawing. But the drawing must be three-dimensional. All the lines must be drawn. No additional lines are added. And the lines are relatively parallel in their length, and their length is similar. A rectangular slanted prism, that's okay, but it really needs to be completed in the way I've just described, and a point is not assigned if any of the criteria I've just reviewed are not met. Then comes you see the rectangle all the way to the right in this top area, what is really a very important test, and I'll describe that more fully in a moment. So this is the clock drawing test, the visual constructional skills. And if I can say this in sort of a global way, if there's one test that you are going to pick that is really sensitive, actually for Alzheimer's dementia, you'll hear that it's a clock drawing test, quite possibly. Because an individual who commits 2 errors, and I'll describe what those might be in a moment, 2 errors or more in drawing the clock hands deserves further investigation for possible dementia. So I just highlight this. We have a lot of material to cover, but you may hear in your work that a clock drawing test is administered, and if there's one test to pick, if I can just say this globally, that's quite sensitive for possible dementia, it's the clock drawing test. But the way you administer this is you indicate to the client this open space in the right-hand, upper right corner here, and give the instructions, draw a clock. Put all the numbers and put in all the numbers and set the time to 10 after 11. There are three possible points here that can be earned. There's the contour of the clock, so the clock face must be a circle with only minor distortions being acceptable. A slight imperfection on closing the circle is an example of an acceptable minor distortion. The numbers need to be all there. So all the clock numbers must be present with no additional numbers, and the numbers must be in correct order and placed in approximate quadrants on the clock face, adequately spaced that way. Roman numerals are acceptable, but the numerals can be placed outside the circle contour. So that's the second point. First point can be given for contour, next numbers, and lastly the hands. Now there must be two hands jointly indicating the correct time. You'll often see people putting a dot in the center of the circle as an axis. But the hands jointly indicate the correct time, and the hour hand must be clearly shorter than the minute hand. Hands must be centered within the clock face with their junction close to the clock center to earn that point. A point is not assigned for a given element if any of the above criteria are not met. So that completes that first section of the Montreal Cognitive Assessment. Next comes naming. So you see the three drawings of familiar animals there. And you say to the client, and beginning left and pointing, moving right to the right, pointing to each figure, you say, tell me the name of this animal, one at a time. And 1 point is given for the following responses. A camel, some people may call it a dromedary, let's say. Next comes, we start with the lion, then comes the rhinoceros or rhino, then comes the camel or dromedary, so in that order. Next comes a test that takes quite a bit of mental acuity and focus, and it again, or should I say, it tests memory. So to pause there for a moment, when we think about memory, we roughly, if you will, we can, and you may hear this referred to in many different points, at many different points in work you do. Memory can be divided into three sections, roughly: immediate, recent, and remote. And with each of these, there's a general concept of how much time is covered in each of these spans. Immediate is typically understood to be within 30 seconds. So you say something to a person and they remember it and, let's say, are able to repeat it back within 30 seconds. Recent memory, within a few hours or days, a person can remember information. And remote memory, more than that, all the way to the distant past. But the memory testing portion of the Montreal Cognitive Assessment then, given that framework, tests recent memory, ultimately. So the way you administer this is the examiner, you read a list of the five words written there at a rate of 1 per second, giving the following instructions. You say, this is a memory test. I'm going to read a list of words that you will have to remember now and later on. Listen carefully, and when I'm through, tell me as many words as you can remember. It does not matter in what order the person says them. And then, as you can see there in the grid offered, here in the middle of the test form, you mark a check in the allocated slot for each word the subject produces on the first trial. When the subject indicates that he or she has finished that first trial and has recalled as many words as possible, then you read the list a second time with the following instructions, saying, I'm going to read the same list for a second time. Try to remember and tell me as many words as you can, including words you said the first time. and then you put a check in the allocated second row of spots of spaces there as the subject recalls as many words as possible on the second trial. After the second trial, you inform the subject that you're going to ask him or her to recall the words again by saying, I will ask you to recall these words again at the end of the test. And again, the whole test takes about 10 minutes from beginning to end. So at this point, the person's going to be recalling the words after approximately 5 minutes. Moving on then, you move to the attention section. And that starts with the forward digit span. So there's 3 components, as you can see, in this attention section. You start with the forward digit span by giving the following instructions. You say to the person, I'm going to say some numbers, and when I'm through, repeat them to me exactly as I said them, and then you read the 5-number sequence at the rate of 1 digit per second. Then you, so that you do that, then you move to the next test, the backward digit span, saying, now I'm going to say some more numbers. And when I'm through, you must repeat them to me in the exact backwards order. And you then tell the subject the 3 numbers there. After that, you allocate 1 point for each sequence correctly repeated. Again, noting that the second digit span group of numerals, you are having them repeat backwards. Then comes a test of what's called vigilance, and we're going to talk about vigilance, what vigilance is, in a few minutes when we get to the next screening tool, the CAM diagnostic test. But vigilance is tested here in the Montreal Cognitive Assessment as follows. You read a list of letters at a rate of 1 per second to the patient. You ask them, you're sitting at a table, let's say, you ask the person if they're left or right-handed, and to put that hand, if they're a righty, the right hand up on the table, if a lefty, the left hand up on the table. And you say the instructions as follows. I'm going to read a sequence of letters. Every time I say the letter A, tap your hand once. If I say a different letter, do not tap your hand. And as you go through there, it may be the print may be fine, but you can see there's a long list of letters there with A's interspersed. And you give 1 point for this test if the person does the task correctly, and if there's with 0, there can be 1 error, and the person can still earn a point, and that's by either tapping at the wrong letter or a failure to tap when you do say the letter A. Next comes what are called serial 7s. You may find the subtraction test referred to as that, serial 7s. And you instruct, oh, my screen just went blank. Hold on one moment. Okay, back on. You instruct the patient for this test of serial 7s as follows. You say, now I will ask you to count by subtracting 7 from 100, and then keep subtracting 7 from your answer until I tell you to stop. You may repeat the instructions if necessary. And the way you score this is as follows. There's some complexity to scoring, but here's how it goes. If there are 3 points available on this test of serial 7 subtractions, you give no points if there are no correct subtractions, 1 point for 1 correct subtraction, 2 if the person does 2 or 3 correct subtractions, and 3 full points if the participant successfully makes 4 or 5 correct subtractions. But here's the finer point. you count each correct subtraction of 7 beginning at 100. Now, each subtraction is evaluated independently. That is, if the person responds with an incorrect number but continues after that to correctly subtract 7 from it, you give a point for each correct subtraction. For example, if the participant starts out by subtracting 7 from 100 by saying 92, well, we know that's wrong, but if the person goes on to say then 85, 78, 71, 64, where the only that first answer, the 92, is incorrect, but all the subsequent numbers are subtracted correctly, well, then you'd give the 3 full points because the person made 4 of the 5 subtractions correctly. Okay, in the interest of time, I'm going to move on, but these 3 tests we've just done in that are all, the most recent 3 I've just reviewed here, are all in the section testing attention. So they as a group test attention. Next comes a language test, sentence repetition. And you give the following instructions. You say, I'm going to read you a sentence, repeat it after me exactly as I say it. You pause and then you say the sentence. Following the response, say, now I'm going to read another sentence, repeat it after me exactly as I say it, and you say the second sentence. And you allocate 1 point for each sentence correctly repeated. Now the repetition must be exact, so you really have to be alert for any errors of omission or substitutions or addition. Moving on, in terms of verbal fluency, is the following test in the language section. You say to the person, tell me as many words as you can think of that begin with a certain letter of the alphabet that I will tell you in a moment. So you're going to tell them that specific letter in a moment. You say to the person, you can say any kind of word you want except for proper nouns. So if, for instance, the letter you were giving the person were B, you cannot use Bob or Boston because those are proper nouns. You also cannot use, or a response that's not acceptable would include also numbers or words that begin with the same sound but have different suffixes like love, lover, loving. You'd only score 1 correct point there. So then you say to the person, I will stop you after a minute. Ask if they're ready, and then say, now tell me as many words as you can think of that begin with the letter F. And then you say, go. You time it for 60 seconds and then stop. You allocate a point if the person generates 11 or more words in 60 seconds. And F is a tricky letter, I find, but that's the test, 11 or more words in 60 seconds. Then moving on, next is the test for abstraction. Now, abstraction is where a person expresses a quality apart from the object. That's how you define, if you will, abstraction, that a person understands or expresses a quality apart from the subject. So this test now, which I'll describe, is an exercise of offering pairs of similar words, and it is a test for abstraction. So you say to the person to explain in the pairs of words you're going to give them what each pair of words has in common, and you start with an example. For instance, tell me how an orange and an apple are alike. Well, if the person says a concrete answer that isn't acceptable, then you can say an additional time, okay, tell me another way in which the items are alike. So you would think that, an acceptable or appropriate answer would be the person would say, how are they alike, an orange and an apple? Fruit. Yes, you'd say they're fruit. Then you go on to give the test after that practice trial. You say to them, now tell me how a train and a bicycle are alike. You wait for their response. The next pair of words you offer them in this pairing of similar words, testing abstraction, you ask, tell me how a ruler and a watch are alike. And you await the response. Now the scoring, again, for this test of abstraction, for instance, with the pair of words train and bicycle, there you could say what would be acceptable is the person would say their means of transportation or traveling, or you take a trip with both. And with the pair of words ruler and watch, they might say they're instruments for measuring, or they're used to measure. But what would not be acceptable, because again, abstraction is that cognitive function where the person understands the quality that's apart from the object. So it would not be acceptable if the person said, for let's say train and bicycle, they have wheels, because that's not apart from the objects themselves. Or for ruler or watch, they have numbers. Those are parts of them, but not qualities that are apart from the object themselves. Then, as we begin to conclude the Montreal Cognitive Assessment, you are now testing delayed recall, because now it's probably been about 5 minutes since you originally gave that list of 5 words in the memory test. So you say to the person, I read some words to you earlier, which I asked you to remember. Tell me as many of those words as you can remember, and you make a check and score a point apiece for those which the person recalls. And then lastly, you ask those 6 questions of orientation. They're at the bottom, asking the person to tell you the date, month, year, day, place, and city. So there are up to 6 points available there. Then you go down the scoring column all the way to the right, where you've marked the number of points the person scores. You see that it's out of 30 total points. You are able to add 1 point for an individual who has 12 years or fewer of formal education. And do note that a final score of 26 and above is considered normal. So that concludes the review of the Montreal Cognitive Assessment, and now I'll move forward through the next, onto the next screening tool. We may go more like 50 minutes, 45 to 50 minutes, given the timing so far. But moving on, and Elaine, I've moved over on my screen to the next.
Yeah, it's not coming. It's not doing. I'll take care of it for you.
Very well, thank you. So here we are. Thank you, Elaine. And now we have the next screening tool, the Confusion Assessment Diagnostic Algorithm, commonly known as the CAM. So we use the CAM when we're considering the diagnosis of delirium. Okay, what's delirium? Well, it's a clinical entity, a diagnosis that is marked by a disturbance of consciousness, and consciousness is awareness, that is accompanied by a change in cognition. Now, we talked about cognition, defined it earlier as knowing something, that cannot be better accounted for by a pre-existing or evolving dementia. Now, just generally, dementia we think of as being defined by a person having impaired memory, with declining mental powers or functioning that, for instance, can have impaired executive functioning, which we defined earlier, that impaired ability to sequence, abstract, organize, and plan information. Now, a hallmark of delirium is that it develops over a short period of time, usually hours to days, and tends to fluctuate during the course of the day. And we'll be going over this as we go through the CAM assessment tool in a moment. But also, there's evidence in the person's history of or physical examination or laboratory tests that the delirium is a direct physiological, so that has to do with, refers to the body's functioning, physiological consequence of a general medical condition, like an infection, Substance intoxication, so the person may have taken or ingested something that leading to the delirium, or withdrawal from that substance. The use of a medication, and I'll just say a few words about that in a moment, or exposure to a toxin or some combination of those factors. So that's a definition, if you will, of delirium. So we use the CAM assessment tool when we're considering the diagnosis of delirium, and as you can see on the screen in front of you, with this tool, we consider the diagnosis of delirium if both number 1 and number 2, you see there on the screen in front of you. So the history, the person presents with acute onset and fluctuating course of symptoms. We'll talk about that more in a moment. Inattention, again, we'll talk about that more. So 1 and 2 plus either 3A or 3B on the screen in front of you. So disorganized thinking and altered level of consciousness. So the way we're using this tool to consider that delirium may be what the person is experiencing is by having number 1 and 2 plus 3A or 3B. Now, this is a very, as you can see at the bottom there, this is a very sensitive and specific test for delirium. And so this is a terrifically useful tool. So let me tell you more about these, the different sections here, starting with number 1, the acute onset and fluctuating course. So one of the keys here is that you, the evaluator, or should I say the evaluator of the person, really knows the person over time and can say with some certainty that the way the person's presenting represents a change from baseline, okay? So that when we're thinking about this point number 1, acute onset and fluctuating course, this, you want to understand the person's current presentation in relationship to or being evaluated with the help of a family member, perhaps a nurse, someone who knows the person over time and can say that in fact the person is experiencing an acute change in mental status. So maybe you've seen the person over the last week and wow, you see the person today and the person's presentation is really changed acutely. Moving on for the sake of time, we move down to number 2, inattention. Now the attention means the ability to hold focus. So what you're seeing in this person's presentation using this screening tool is that now the person is inattentive. They could be easily distractible, having difficulty keeping track of what's being said. They're not able to hold a focus. Then moving on, you look for, you're evaluating screening here for disorganized thinking. So is what the person's saying, is the way they're thinking somehow disorganized, incoherent? Is the person rambling or talking about things that are irrelevant to the conversation or somehow unclear or illogical? Then also you assess for a possible altered level of consciousness. Now, that means the person has a fluctuating level of alertness. And the person can either be hyper alert, so hyper vigilant, or have decreased alertness. They can be drowsy, difficult to arouse, which is called stuporous, or actually unarousable, possibly even in a coma. So what is important here, this is such a useful tool. It can be used in acute care settings like hospitals, if a person has an acute change, let's say after surgery, or if they've been admitted for an acute infection, let's say in a long-term care facility, in a nursing home where the person, you hear, wow, you know, Mrs. A or Mr. B, that person is, that nursing home resident really is different today. You want to be aware of the possibility and screen for a possible delirium. But also this can be done at home, let's say in a home care, with a home care clinician, seeing someone, let's say, who's been discharged from the hospital post-operatively or after an infection, treated for an infection, and the person has changed in his or her presentation, over a brief period of time. Maybe the person, then you can think, using this information we're reviewing now, wow, the person has a new cough or a new fever, or is having urinary incontinence that's new, might have a urinary tract infection. Maybe has been started on a new medication, and there are a number of medications which are considered, if you will, possibly delirium-ogenic. They can lead to deliria. So there are certain sort of possible likely culprits, medications with strong anticholinergic side effects, or medications sometimes like benzodiazepines. But that's subject for a whole nother talk. Medications that have more like a higher probability than others of possibly bringing on a delirium. But again, for our purposes, the confusion assessment method, the CAM diagnostic algorithm, is used as a screening tool for delirium. Moving on, Elaine, if you'd move us to our next screening tool and screen.
Sure.
Tell me when you're ready. There we go.
We are
terrific.
Ready.
The CAGE assessment for alcohol abuse. Okay. This is a self-report questionnaire. And you give this form, this questionnaire, you can give this questionnaire to the subject, and you say, please fill out the form below. So this is not used, this is used as a screening tool for alcoholism. So the CAGE questionnaire, a screening tool for alcoholism. Why is it called CAGE? Well, that's an acronym. You can see the 4 questions. It's a very simple, really powerful tool, screening tool. And they come from the highlighted words you can see here on your screen. So the questions are, have you ever felt you should cut down on your drinking? So there's the C, the first letter of cut. Have people annoyed you by criticizing your drinking? There's the A, beginning annoyed. Have you ever felt bad or guilty about your drinking? There's the G, guilty. Have you ever had a drink as an eye-opener first thing in the morning to steady your nerves or get rid of a hangover? So here are the 4 questions on the CAGE questionnaire. So that's how the questionnaire gets its name. And as you can see, it is a screening tool for alcoholism. It does not talk about quantity or frequency of drinking. It is a screening tool for alcoholism. And part of the power of this, part of the usefulness, is that the CAGE questions are so simple and easy. It's easy to administer. And it can be administered in almost any clinical setting to identify a patient who would require more extensive testing and possible treatment for alcoholism. So the CAGE questionnaire is really one of the most efficient and effective screening tools we have. Now, do note that a score of 2 or 3 yeses on the CAGE questionnaire indicates a high index of suspicion for alcoholism, and a score of 4 is virtually diagnostic for alcoholism. So again, it's used as a screening instrument rather than a diagnostic instrument. So it is a screening tool because, again, it doesn't provide more information about quantity, frequency, or pattern of drinking. So it doesn't lead to diagnosis, but it is an effective, easy-to-use screening instrument. And, part of the tragedy is that alcoholism and other addictions, do respond to treatment, but they are under-detected. And using the screening tool can lead to such the hope of a greater identification and then treatment and benefit from the treatment for alcoholism. The CAGE questionnaire was developed about 25 years ago and has been validated by numerous studies as really a good, quick primary indicator for the need for further investigation for possible alcohol abuse or dependence. And it really is underused, the CAGE screening questionnaire, so that, unfortunately, with that underuse, alcoholism is often undiagnosed and then untreated. Okay. Moving on, Elaine, if you'd move us to, great. The PHQ-2. Now, as the CAGE questionnaire is a useful, simple screening tool, so then absolutely is the PHQ-2. So PHQ, that stands for Patient Health Questionnaire with just 2 questions on it. You can see those 2 questions. And our last slide, which we'll get to in just a couple minutes, is the PHQ-9. So it's a version of the Patient Health Questionnaire with 9 questions. So the PHQ-2 is sort of the entry level into the PHQ screening tool framework. And the PHQ-2, what I want to stress here is that the questions on this and on the PHQ-9 are linked to, if you will, derived quite sensibly and usefully from the diagnostic criteria in the Diagnostic and Statistical Manual, that is the standard for diagnosis in mental health. The current version being the DSM-4, then TR. The DSM-5, the newest version, will be published fairly shortly. But the questions here are linked to the Diagnostic Manual for criteria for diagnosing depression. So the PHQ-2 inquires about the frequency of depressed mood and what's called anhedonia, which is lack of pleasure that the person may be experiencing. Over the timeline is 2 weeks. And again, this is linked to diagnosis of depression in the Diagnostic Statistical Manual of Psychiatry, of mental health. So it asks about, the PHQ-2 screens for depressed mood and anhedonia over the past 2 weeks. And the 2 questions here are the same first 2 questions that are on the PHQ-9. So the purpose of the PHQ-2 is not to establish a final diagnosis or to monitor depression severity, but rather to screen for depression in a first-step approach. It's just 2 questions. You see how this could be easily put in waiting rooms of primary care physicians' offices, other healthcare settings, and a readily available, easy to use, just 2-question first-step approach to screening for depression. So patients who screen positive, and I'll define that in a moment, should be on the PHQ-2 should be further evaluated by the PHQ-9 to determine whether they meet criteria for a depressive disorder. So the clinical utility here, why would we use this? Because reducing a depression evaluation to 2 screening questions enhances routine inquiry about this most prevalent and treatable mental disorder in primary care. So as you can see here, for each of the 2 questions on the PHQ-2, you can have a score of up to 3 points. And so the PHQ-2 score ranges from 0 to 6. And the authors of the PHQ-2 identified a PHQ-2 cutoff score of 3 as the optimal point for screening purposes. So if a person scores 3 or more, then you really want to move on to the PHQ-9. And again, just to wrap up here on the PHQ-2, you can see the questions asked are in the time frame of the past 2 weeks. Have you been bothered by any of the following? Lack of interest or pleasure in doing things, feeling down, depressed, or hopeless, and then there are numerals to circle or check off, and that's how you score the PHQ-2. In the interest of time, I'll use that as a segue to the last slide, the PHQ-9. And so this is the more expensive patient health questionnaire, but again, it's key to the Diagnostic and Statistical Manual, the book where the criteria for diagnoses in mental health are listed, and this is about depression. So for the initial diagnosis here, the person goes through the PHQ-9 like they did the PHQ-2. I'll just say that given our last few minutes here. And the person goes through the all 9 questions on the test, and it's scored in such a way where the total score is interpreted, and you can see with 9 questions and up to 3 points apiece, a person could score with severe depression. A person with severe depression, if you see a score, let me put it this way, if you see a score of 20 to 27 on this test, the diagnosis of severe depression should be certainly considered. 15 to 19, moderately severe depression. 10 to 14, moderate depression. 5 to 9, mild depression. 1 to 4, total score, minimal depression. But again, that top score of 20 to 27, you have to consider the diagnosis of severe depression. But again, this is a screening tool, so all responses need to be verified by a clinician to make a definite diagnosis, and that could most reasonably be done by a mental health professional. Just to highlight a few points on the PHQ-9, and then we'll wrap up. If you look at questions 4, 5, and 7, question 4 talks about feeling tired or having little energy. Question 5, poor appetite or overeating. Question 7, trouble concentrating on things. Again, the questions here, can you hear me?
Yeah, we can.
Okay, the questions here are parallel the diagnostic statistical manual. And then the questionnaire finishes there with impairment of functioning that the patient may also highlight. Just to finish then, to emphasize, these last 2 screening tools, the PHQ-2 and PHQ-9, are for depression. And being a geriatric psychiatrist, let's just understand that depression is not a normal part of aging. It is not a given that as you age, you become depressed. But these are particularly important, and given now just the new data in the last day or so that's come out, suicide in the elderly is really epidemic, and so it has a high rate than any other age group. And these screening tools are easy to use for depression and can lead to great benefit and safety in caring for patients. So why don't we stop there? I do have 4 other tests I can just mention briefly, given the time we have, but now we open it up for questions.
Yes, if anyone has any kind of questions, remember, too, we also have Mr. Tom Snyder online. I know we have a lot of employees that work for him, and we're available for questions. Just type them in for us. Also, at this time, you can see your link to the Survey Monkey for your post-test once we shut down. And if you're not at your own computer, remember to copy that down. I would like you to go on and do that if you don't mind, because if we do end up with any questions, we might need to bounce back and forth to some of these assessments so we can answer your questions and see that test at the same time. So are there any questions out there? I don't see anything coming up. Go ahead, Dr. Weiner. Tell us about the other assessments.
So just briefly, literally in a minute or two, I'm just going to mention 4 others that you may encounter, so you just have a beginning familiarity with them. First is called the Cornell Scale for Depression in Dementia. So this is we just talked about PHQ-2 and PHQ-9, self-reporting questionnaires. The utility, the usefulness of the Cornell Scale is that it is used to evaluate depression in patients with dementia. So it's a caregiver who completes the form. And so if a person, him or herself, can't fill it out because of dementia, can complete it, a caregiver can. So this is a useful screening tool for depression in dementia. Next, I'm just going to mention something called the Global Assessment of Functioning Scale. You'll find that in the DSM-4TR, and this is used to, it's a numeric scale used subjectively to rate social, occupational, psychological functioning in adults. So you may just hear about a GAF score, GAF, Global Assessment of Functioning. It's a screening tool that you may see used by evaluators, even insurance reviewers, about how a person's functioning is assessed. To wrap up then, there's what's called AIMS, commonly known as the AIMS test, AIMS, an abnormal involuntary movement scale. You may see this you would see this typically in a patient being treated with an antipsychotic medication, and it's used for detection of extrapyramidal side effects or early detection of what's called tardive dyskinesia, which can be a side effect from long-term use of antipsychotic medication. And lastly, a standard screening tool for dementia. Remember, the Montreal Cognitive Assessment was for clinical entity called mild cognitive impairment. A standard screening test which you may encounter for dementia is the Folstein Mini Mental Status Exam, MMSE. And it's a 30-point, one-page screening tool like the Montreal Cognitive Assessment, but this is for dementia. 30 points total are available. Just note that if a person on the Mini Mental Status Exam test scores between 26 and 30, one should be vigilant, aware that a dementia is highly unlikely. A 21 to 25 score, mild to moderate probability, and 0 to 20 on the Mini Mental Status Exam, a high probability that person may have dementia. So those are just 4 additional screening tools I mentioned.
Okay, well, great. Well, I don't see where anyone's asking any questions. I think you must have done a really good job at explaining everything.
A lot of information
you were very thorough.
To cover. I greatly appreciate everyone's attention and interest. I hope this has been informative and useful. Thank you so much for taking the time to participate in this webinar.
Okay, thank you very much, Dr. Weiner, and thank you, Mr. Tom.
My pleasure. Thank you very much.
Okay, everyone have a good day.
You too. Bye-bye.
Thank you. Please stand by.